So what it seems like, and this is, and I'd like my colleagues to weigh in, is you are in part making decisions on past history. So how did Mrs. Jones do in her prior therapies? You're in part making decisions based upon current functional status and trying to be a bit provocative. You're then making decisions on some subset analyses from prospective trials and trying to, and using those subset analyses to identify patient populations that might benefit from one approach versus the other. And I don't want to put words in your mouth, and certainly we all do this, but there is a bit of a paucity of data to help us compare many of the decision-making trees that we have around choosing treatment A, B, C, or D, when they're all basically approved in the second-line setting, never been compared in the second-line setting, and yet each one is trying to demonstrate to us and to others why theirs is the preferred treatment in the second-line setting. So David, you're the honest broker. Help us figure that out.
Well, I think what you said about a paucity of data and what we choose to believe is very important. I think we're moving forward the best we can in terms of selection. So, for example, if it's said that if we have a patient that's on their first VEGF TKI, could be first or second line, whatever, and they go more than 180 days, there's a subsequent benefit to VEGF TKI, a further VEGF TKI. But that comes from a study where we looked at sequential sunitinib and either sorafenib and temsirolimus. And is also supported to some extent by the results from the AXIS study where exitinib in those patients that had more than 180 days of sunitinib first line did well. Beyond that, the rest is our balance of what we kind of choose to believe, and it is kind of difficult. We have beliefs about tempo of disease. So some people will say the patient is growing rapidly after pazopanib or on the back end of sunitinib and pazopanib. I really feel like I should give VEGF TKI, which would be cabozantinib, rather than an immunotherapy because I think I'll get a more rapid response. The evidence doesn't actually support that. We have no comparative evidence, but the responses to immunotherapy and cabozantinib are relatively quick, and you end up with an issue of working out what the kind of benefit's going to be. The other issue is related to the comorbidities that a patient brings to the table. So most of my patients in the second line, I'm going to give them nivolumab because it's well tolerated and I think they want to break from VEGF toxicities. But cabozantinib is a great drug. It's probably our best VEGF TKI inhibitor plus. I tend to reserve that for a group of patients that are bad actors. They have organ transplants, they have autoimmune disease, or something else that's going to make me not want to give an immunotherapy. So from that perspective, I'm selecting out those bad actor patients to put on a drug where I might have considered there was variable tolerability, there was some toxicity. In actual fact, they've handled it quite well, and I've been surprised at how well they've done. So there's some issues with what comorbidities the patients bring to the table. And then we've got oral and intravenous administration, which doesn't really alter my selection, although you do have some patients that don't want to come to the clinic every 2 weeks and are happier taking a pill and trying to correspond by distance and telephone.